Right. The House Appropriations Subcommittee on Medicaid and Behavioral Health will come to order. Mr. Clerk, please take the roll.
Chair Van Workum.
Here.
Vice Chair Green.
Present.
Representative Ross.
Here.
Representative Coon. Here. Representative Robinson.
Here.
Vice Chair Rogers.
Here.
Representative Blandeville.
Here.
Mr. Chair, you have a quorum.
Thank you. Representative Green moves to approve the minutes of the June 24th meeting. Seeing no objection, the minutes are approved. Thank you, everyone, for being here. I know it's been a little time since this subcommittee has met, but we got some important issues moving forward. As you know, we've been talking in full approach about the Rural Health Transformation Program. We have Beth Nagel, the Senior Deputy Director of Policy Planning and Operations Support Administration, here today to give an update where they are in the process. And then I think we'll have plenty of time for questions of members on how we got here and maybe some on the specifics of the proposal. So with that, Ms. Nagel, the floor is yours.
Thank you very much. Good morning. I appreciate the opportunity to come and talk about the Rural Health Transformation Program. Today, I'm going to talk about a couple of things. I'm going to start with just a very brief overview of the Rural Health Transformation Program. I'll walk through the budget for Michigan's activities. Then we'll take a closer look into those proposed activities, as well as our funding distribution methods, and then a quick update on the advisory council that we're forming as well. For that brief recap of the Rural Health Transformation Program, it was created in H.R. 1, which was signed in July of 2025, to be administered by the Centers for Medicare and Medicaid Services, or CMS. It's $50 billion nationwide over 5 years. CMS set the framework for the grant to be transformational. This is not to supplement existing activities, but to expand or enhance service offerings in rural Michigan. The opportunity was released on September 15th of 25. The proposals were due in November 5th actually, of 2025, and then CMS made their first awards for year one, or $10 billion of the program, on December 29th of 25. Michigan received $173 million, and our very first activity in this process was to revise our budget that we've submitted in the proposal to match the award that we received. And so I will take you through that. We were able to update the budget without cutting any activities or any funds or any funded programs. What we were able to do was learn much more about what CMS expects of us in this first year. And so we were able to cut personnel, fringe, and travel quite significantly. And then also look at our contractual items, and I'll walk through those in a moment, to be able to see what activities were ready to be implemented and should be funded in the first year at full implementation costs, and then what other activities might need some planning time, some ramp-up time, some capacity building. And so I'll talk through that. I also want to draw your attention to the contractual administration line, and I'll show you a little bit more on that on the next slide. CMS has quite firmly capped all administrative costs for this program at 10%. They consider administrative costs to be personnel, fringe, travel, and indirect costs. And so the contractual admin line is meant to reflect those types of costs in the entities that will be doing this work. So the hospitals, the clinics, the community organizations. That contractual admin line is not meant to stay at MDHHS, but instead be passed on for the work that will happen in these communities. And so we have to carefully monitor this fund separately. And so that's why it appears separately in the budget per CMS. All right, I will now talk about the activities that we proposed in the Rural Health Transformation Proposal for Michigan. It largely falls into four main categories. The first one is called Transforming Rural Health Through Partnerships, and that one is focused on chronic disease prevention and management innovation in communities. And I'll talk through the activities in subsequent slides. The second is Workforce for Wellness, making sure we have a strong workforce now for rural Michigan for the activities that are already underway to take care of citizens and any new transformation as well, with an eye on the future healthcare workforce supply as well. Our third one is called Interoperability in Action, or you could also say it's our technology area, focused on getting providers the tools that they need to do their jobs in an efficient and effective way. The last one, the last area of focus we're calling Care Closer to Home. And this is to reduce travel burden for patients by making care available in the community in a variety of innovative ways. I'll go through each of these areas now in a little bit more in depth, and you can see some of the budgeted amounts as well. So in our Transforming Rural Health Through Partnerships activity or area of focus, there are two main activities. They're listed here. The first one is Chronic Disease Collaborative Care Fund. And this one is meant to fund and implement innovative collaborative approaches to chronic disease prevention and management, like diabetes education, hypertension management, or utilizing community health workers to coordinate care. By piloting these innovative solutions with local health departments, federally qualified health centers, school-based clinics, rural health clinics, hospitals, community organizations, and more, this initiative is meant to expand access to integrated care. The second activity is called Collaborative Care Integration and Sustainability Fund. This fund is to support the technology to screen populations and provide meaningful, brief interventions and resources, then close the loop with repeat screenings and referral when needed. Targeted efforts will focus on improving the health and well-being among children, adolescents, and families, including initiatives that support behavioral health and prenatal care through partnerships with school-based clinics, child and adolescent health care centers, family resource centers, and more. In addition, these projects may also focus on strengthening cross-sector partnerships between the area agencies on aging to promote coordinated care and preventative health strategies for older adults. The second area of focus was the workforce area. And there are two main activities listed in the workforce activities. The first one is meant to be future focused on making sure that there's a strong, steady supply in Michigan of healthcare workers that starting as young as possible, looking at high school to healthcare career path, talent pipelines, internship programs, establishing rural residency programs, and other trainings for providers with tuition assistance. The second activity is meant to provide direct recruitment and retention assistance to Michigan's healthcare system. This is the Rural Provider Recruitment, Retention, and Capacity Fund that is meant to help providers across the entire spectrum of behavioral health, maternal health, physical health, emergency services as well. These types of interventions for recruitment could be housing assistance, relocation expenses, and retention programs like longevity bonuses, training opportunities, career ladder programs, and apprenticeships. The third area of focus is the technology area, or interoperability in action. The first activity, the Rural Data Integration and Infrastructure Fund, is the kind of the large bucket where we are accepting proposals for whatever providers need to enhance their services. So this is implementation of new or upgraded electronic health records, telehealth equipment, secure messaging, and special projects for remote monitoring for care management tools will also be considered. Any other emerging technologies that enhance access, coordination, and quality of care will also be considered in this fund. The second is the Rural Access and Connectivity Fund. This fund is focused on expanding access to social service and community resources through connected systems and real-time information sharing. This is often referred to as community information exchange. The goal is to coordinate screenings with community services in a way that is easy and secure for residents. And lastly, we set aside $2 million for Rural Interoperability and Governments Fund, which is meant to provide training and technical assistance for the tools that will be in place through either of these other activities. So making sure that not only does the funding provide for the tools that are needed, but any national experts or national technical assistance to be able to implement those successfully. The last area, Care Closer to Home, is split up onto 2 slides in my presentation. The first activity within this area of focus is called Promoting Healthy Aging in Rural Communities. And this is meant to implement care transition and support services, which is like a proactive discharge planning when patients are discharged from hospital settings. This also supports the development of rural PACE alternative care settings that provide adult day services and clinical care in smaller, locally accessible facilities, and preparing homes of older adults for potential emergencies. The second activity in this fund is care delivery hub and spoke models. This fund is to establish coordination between traditional healthcare service providers today and community-based organizations to extend their reach into rural Michigan to services like preventative care, management of chronic disease conditions, maternal health, and mental health services, including substance use disorder. Some examples could be in-home care, using alternative community settings, mobile care, or specialty telehealth care. Continuing the Care Closer to Home area, there are 2 additional activities to round this area out. The first one is improving care and delivery and access through transportation. This one is meant to support the enhancing of access to non-emergency medical transportation, specific transportation services for maternal health care and support, transportation to services needed for healthy living, and addressing inpatient behavioral health transportation gaps as well. The last area of focus, last activity in this area is advancing rural behavioral health. And this is meant to expand the service array and increase the acuity levels able to be treated in rural Michigan with services like intensive outpatient programs, crisis stabilization units, crisis intervention, behavioral health urgent care, and mobile medication units. So those are the activities. I've gone through a bit of the budget for each one, and I'm sorry, I skipped ahead. I wanted to talk about 3 other activities that were included in our proposal as well. Pardon me. The first is funding for tribal health. The 12 federally recognized tribal governments in Michigan and the American Indian Health and Family Services had a 5% set aside from our award that will be used to split evenly among those 13 entities that are interested in working on this funding. They'll work closely with DHHS to develop plans that meet the goals of our proposal and CMS as well. This arrangement recognizes the unique needs of the tribes and the critical role they play in protecting the health and wellness of their communities. The second activity was a requirement from CMS for evaluation. This funding will go toward toward evaluation tools, evaluation technical assistance, and the development of data dashboards to show progress. Lastly, $2.5 million was set aside to provide technical assistance and administrative support throughout implementation to ensure compliance with state and federal requirements and also strengthen coordination across initiatives. Okay, now I will talk about how we plan to get the funds out the door, which is one of the biggest questions that I get. There are 2 specific ways that we are looking at moving these funds. And as you may recall, this is one of CMS's top priorities, is moving the funding. And so there are two main ways. One is through directed grants. And this is where, in our proposal, we listed a specific entity type that will do a specific scope of work. And so an example of that would be our healthcare, our high school to healthcare pipeline. We wrote into the grant that the area health education centers were identified to develop those programs throughout the state. So this would be a directed grant to the area health education centers, or AHECs, which are throughout Michigan's rural areas, to develop the specific scope of a high school to healthcare pipeline program. And that goes through a directed grant process where we are able to say, are you interested in this program? Tell us more about it. How much will it cost you? And then we are able to enter into an agreement, being able to pass on all of the requirements from CMS in that process. It is meant to reduce the burden for the providers and the grantees, and to be more of a direct mechanism from the department. The second area, the second way that we plan to move the funding is through proposal-based grants. And these are opportunities where they are open to a wide array of entities with a generalized scope, but really provides for flexible solutions that are tailored to the community needs. So this will look more like a grant-funded opportunity, which is sometimes synonymous with a request for proposals. An example of this would be our technology fund, where in the Rural Tech Innovation Fund, we would be used to essentially offer the funding up and say, what do you need? Tell us, how you will use it. And we're able then to provide the funding through a proposal that is specific to the community or specific to that organization's need. Additionally, we will be using a prioritization framework as well. We utilized the Federal Office of Rural Health Policy data set for determining rural in Michigan. And that data set said that there are 58 fully rural counties in Michigan and 17 partially rural counties. That is just the beginning, the first step of distributing the funding. The rest we will work through this prioritization to look at multiple factors that target the highest need areas. For partially rural counties, that will include the percentage of rural population. For all applicants, we will consider chronic disease prevalence, access to hospitals, primary care, OBGYN, and mental health services, as well as the prevalence of Medicaid and socioeconomic factors like child poverty rates and the percentage of the aging population in that area. Lastly, an update on the advisory council that we are forming. We sent out a notice of the advisory council and a call for nominations on January 13th. We were surprised and excited to see 226 excellent applications. We are working through those applications now to get the right mix of statewide representation and system-wide representation as well, and we're hoping for a meeting yet this spring. Lastly, our website, michigan.gov/RHTP, has the full project narrative and also a summary, as well as the ability to sign up for a listserv so that information is delivered right to your inbox. And with that, I have the contact for Sharday Burton, our Legislative Affairs Director, for any follow-up.
Thank you very much for the presentation and the update here. I know some members have some questions yet. I know you presented at the full committee, yet there's still some, I think, questions yet of how we got to where we are in the process and the process moving forward. So I want to thank you for providing kind of that first tranche, so to speak, of where those dollars are going. I know we got some questions about that. When I first saw where we kind of ranked in total funding of being at 43rd. And then kind of doing some of the statistics out there showing that we have the 8th most rural population in the country. So even if we got to closer to our Midwest neighbors in the 30 range, 25, 30 range, that's about 20 to 30 million more dollars available that we could be putting into rural health. With your have you had conversations with CMS about how we were put into that 43rd spot? And have we asked for our score, and have we received our score from CMS?
Thank you for that question. We actually just were assigned a project officer last week. We met with that project officer for the first time this week, and we have not requested that information at this time.
Why haven't we requested our score at this time?
Our very first meeting was filled with an agenda from CMS and what they wanted to cover and the information that they needed to relay to us.
Are we planning on asking for the score?
Yes.
All right. Representative Roth?
Thank you, Mr. Chair. Appreciate it. Thank you, Ms. Nagel. One of the things you started out with was how CMS was going to give us the money with more technology, that kind of thing, electronics stuff. Wasn't there also a chance to ask for programmatic issues as long as it wasn't a program that was already underway? So if I had we're delivering babies at Munson and Traverse City, that's no. But if there was an area like in Northeast Michigan where they have no birthing services, can't we ask for that in that program as long as it wasn't something we're continuing with?
Yes, CMS was very clear that this is not for continuing operations,
Correct.
but this is for new and innovative delivery of care. And so I do think that there is opportunity within our grant proposal for situations like that.
Inside of what we have been granted.
Yes.
Okay.
Representative Robinson?
Thank you, Chair. I want to follow up on a question that Chair asked. When you found out that we were so low and our rural was so high, have you guys speculated on the scoring? I mean, you guys, even though you haven't requested it, I'm sure you've had some discussions about it. Could you give us your purview on why you think that is?
Yeah. So CMS actually published how they would score well before the proposals were due, and 50% of the award is just split between all states, and so all states received 50% of the $10 billion equally. Then 25% was graded on specific metrics. Percentage of rural population was one of them, but it was one of many of them. There were metrics on how many community mental health organizations we have in rural Michigan, how many of our hospitals received disproportionate share payments, things like there were a very long list. And Michigan has made some significant headway in some of those areas that I think actually disadvantaged us with the scoring, because this funding was meant to highlight the highest need. And so, I do think that looking at the scoring and how it all scored, and even some of the early estimates that other organizations did, like Kaiser Family Foundation did an estimate before the proposals were even due on what each state would get based on that long list of factors, and we're about right where they said we would be.
As a follow-up to that, so can you discuss the metrics that measured that were listed in the proposals that were created? Who went into formulating that?
That would be CMS.
Okay, did MPHI have anything to do with that?
No, this was CMS, a
Okay.
grant from CMS.
Okay.
Yeah.
Okay, go ahead.
So they scored the proposal.
I think what he's referring to in your proposal, you have a series of metrics that you came up with of having 150 new community health workers or 150 new providers at the end of this process.
Thank you.
And asking how we come up with those metrics.
Okay, thank you. I apologize for that. Yes, we came up with those metrics largely working internally and with several of the organizations like the Michigan Health and Hospital Association, the Michigan Center for Rural Health, the Michigan Primary Care Association, and the Michigan Association of CMH Boards.
Yeah, I wanted to follow up on some of the scoring process. Now, I believe 20% of the scoring process related to the Make America Healthy Again priorities of the Trump administration. And looking at the application, it kind of looks like we just didn't do that part of the test. Like you get scored of a test and a proposal of we did not include anything related to the presidential fitness test. There was no mention of House Bill 4305 as it related to snacks and SNAP, and that would have given us 25 points there. There's some licensure compact. We did not receive points for introducing 4246, which I believe is a Representative Green bill, and 4390 that deals with the licensure compact. And those were some things that we could have gotten some easy points to do. I guess one question here is, did the administration approach the Speaker or the Senate Majority Leader about introducing some of these legislation? And just knowing that some of this legislation was out there and already introduced, why wasn't that included in that section that could have bumped up us with that 20% section of the application?
So I can't answer if the administration approached the Speaker. I'm not aware of that. But I can answer that CMS did clarify that those needed to be bills that were passed in order to get that funding. And so just having a bill introduced wouldn't have given us that specific funding.
The information that I saw was if it was introduced, it would be 25 points. If it was actual state policy, it would be 100 points for that category. So some of them were broken down based on whether it was just introduced, and some could have been executive order or something like that to get those points. So still curious about the process there. And then secondly, since these things are to light and we know that these bills are there, is this something that the administration is looking to incorporate or work on? I know some of them, particularly dealing with nutrition, continuing education, that one's due in fiscal year 27. Is this something that you plan on updating the proposal with to include this? And secondly, should that be included, do you believe that CMS would adjust the amount of money that we would be then receiving in the future?
So several questions there. I'll start in reverse. CMS is committed to adjusting the amount every year. They have made that clear that they will look at metrics of success across all states and then reshuffle the funding. So that is one part of the funding matrix, is that it will not look the same from year to year. So I do think that that is true. I will certainly look into getting every point possible, and so I will certainly follow up and try to find more information about what you've described. And lastly, I would have to defer to Sharday Burton for any other questions about what the administration is planning.
Thank you. Representative Rogers?
Thank you, Chair. So I have two questions. One is more processy. Thank you for kind of giving us the overview that 226 applications were received. Can you give us an outline of a timeline of when the announcement will be, when it's chosen who will be on the task force?
This is for the advisory?
Yes.
Yes. We are trying to get through those applications as fast as possible. We want to have a meeting yet this spring, and so we're hoping for it as soon as possible within the next week or so.
And do you have any kind of buckets you can share? Like, I would imagine behavioral health bucket, do you have certain seats that you're aiming to fill with the decision making? Is there anything you can share in high level terms?
I would have to look back at that to make sure I didn't miss one, but I can provide
If you can
that
follow up,
information.
yeah, that'd be fine. And then what is the vision for, I appreciate you being here with us to share some of these, but what do you envision, because this is a large appropriation, is there any kind of vision to have input from the legislature as you deliberate over these funds and how they're expended?
That's a great question. I'm not sure. Are you asking about a formalized process? Yeah, I'm not sure that I have any plans on that, but certainly open to that.
Thank you. And then just one more, if I may, Chair, going back into the, you outlined some of the things on here about IT. We have some infrastructure in Michigan through MyHIN and some of the data sharing, but we still continue to have some areas, I think particularly in rural areas, where there's redundant tests because provider A can't get the information from provider B, and it's a time-sensitive, urgent matter for some kind of medical process. So while I understand that CMS is saying you can't do investments in existing things, are there new initiatives from the IT that you can give more specifics on from an IT and connectivity standpoint?
Yes, and thank you. That problem that you describe is actually what has driven our programming in that area, in the technology area, and why we focused on interoperability for that reason. We maintain it is not enough to utilize a tool like electronic health record, but it needs to be able to be shared in a way that makes sense for the patient. And so that is a main goal of that activity.
Thank you. I really appreciate that aspect.
Representative Green.
Thank you, Mr. Chair. I have two quasi-related questions, if that's okay. If you were to sort of sit there and rank or to give probabilities, part of our next year's funding is that we are able to utilize this year's funding. So we are now sort of at, what are we at, 1st of March. You said you have 226 applicants for $173 million. Are we going to end up with too much on our balance sheet that it's going to affect next year's grant allocation?
The 226 applications were for nominations for the advisory council.
For the advisory council.
Yes.
Okay.
So that it's not related to
Not related, but are you confident that we're going to be able to get the money out, that our system is set up where we can accept grant applications and get the money out to them so that we are not affecting next year's award as well?
Yes, so we have between December 29th of 25 to October 30th of 26 to obligate these funds, and they can be spent into the next year. And so our funding for next year, one of the CMS has told us one of the largest indicators of funding for next year will be our ability to get the funding out in the obligation period between now and October 30th of 26.
So when are we looking at getting those obligations?
We are moving forward as quickly as we can with those directed grant opportunities, and then preparing all of everything that we need for the larger proposal-based activities.
So April 1?
You know, there are so many different factors that will affect exactly when I can get the funding out, including CMS approval, and so I really can't commit to a date.
Okay. Second question that I have is just how rural communities function. Many times we function on a shoestring, thus we have funding issues, right? And we don't always have a team of people sitting there writing grants. Mm-hmm. And so you get to a more populous or a more wealthy community, and they have multiple people there that can write grants and so on and so forth. What are you doing to mitigate that so that our truly rural, whether it's the Thumb, the Northern Lower, or the UP, actually has access to people who can write the grants and get that, so that we're not just getting it sucked up by people who have a profession of writing grants?
Mm-hmm. Yeah, that's a great question and one of our top concerns for sure. The directed grant process is meant to alleviate that burden. So that it really is simplified and the bulk of the work ends up back on the department's end to get all of the information correct and entered and ready to go. And so we've had some good feedback so far on that process to alleviate some of those concerns. Secondaries, there are the proposal-based grants, we do need to know some information. What do they want to do with the funding? How will they measure the impact? Some of those activities. And so recognizing that would be a burden on some of those rural communities, we have engaged the larger associations to either help with technical assistance for those areas or be the fiduciary for those areas as well. So we're working through some of those mechanics to make sure that the burden isn't on those rural communities.
Representative Roth.
Thank you, Mr. Chair. Thank you again for being here. Are we going to engage with communities as we go along? Are we counting on the advisory committee to do these actions for us? And would that mean that we better have people from all our different communities in the state be part of that, including the UP?
Yeah, absolutely. So twofold. The answer is yes, the advisory council is a very important part of that. But the other part of it is being able to engage with those counties. And so we are looking at we're hitting as many annual conferences as possible to reach as many people as possible to get the word out and have these conversations and we're doing that just for ease to try to get events that are already established, but we are also planning an annual summit specific to rural health transformation as well.
How many members of the council are you envisioning?
Yeah, anywhere between, we're kind of looking between 23 and 18. We want to be able to have it, function, not too many people, but certainly be able to grab all of the areas of the state and all of the different professions as well.
And I would recommend the engagement also. There was some frustration that I heard from some of the listening sessions that were taking place, the Marquette, Traverse City one. That it was more about what the department was going to do and less about what the community was asking for. Okay. So I encourage you to continue those listening or engagements and making sure you're hearing what the rural communities are saying.
Thank you.
Representative Glanville.
Thank you, Chair, and thank you for being here and answering all of our questions as well. There's a lot coming at you this morning, so I appreciate it. I have a couple of questions related to a little bit more of the back end of the programming, particularly around the technology piece. Often, my experience, and I think many of us are aware of this, is that, we have these fantastic program ideas, but we don't always necessarily recognize the human resource and other costs that kind of go into the back end of it to making sure they're successful. And to the point of some of my colleagues, do you have the staff you need to do these listening sessions? Do you have, the resources in that regard that might be outside the scope of this funding from the feds? So can you speak to that a little bit about what resources you anticipate needing for this work, and then also not only within DHHS and others, but thinking about DTMB and the support for technology. I know that they assist with putting these all the reporting structures and grant applications and all of that is in partnership with them. So do you have a sense of the amount of work that might be going into this that we might consider supporting?
That's a great question. Thank you. We do think a couple of things. There's a couple of issues at play. One is the 10% cap on administration with these grant funds. We really wanted to make sure that gets passed on to our partners. And so it is very lean on the department side. We are focusing on getting the funding out and supporting grantees at this time. So some of the, the larger engagement activities, we are using staff time for other purposes for that, not charging that to the grant.
Okay. And again, kind of keeping with technology, have you had any conversations about how this partners with other initiatives in the state, particularly with broadband access and making sure that folks can access these innovative technologies that will help bring healthcare to our rural areas?
Yes, and thank you for that question, because we were hoping that this funding would help with some of the broadband access and some of the larger access issues in communities. It cannot. And so CMS has prohibited it. So we are looking for ways to partner and to make sure that that is a successful, that is a component that is considered as part of the success of these programs.
And would that be a follow-up with Charday to kind of dig into a little bit of what other appropriations might be necessary to support this programming?
Yes.
Okay. And then if I may, one final question around the education piece, the workforce to wellness. I continue to be a little bit concerned about, I appreciate apprenticeship programs and helping our high school students and our communities, make those transitions, but I feel like we continue to lower sometimes. We're relying more and more heavily on younger and younger people to do maybe some highly skilled jobs. And so I guess my question here has to do with, we've also seen at the federal level changes in, for example, with medical doctors, that there's a cap on how much can be borrowed now to be a doctor. I believe it's $200,000. So I'm just wondering if there are other things at the federal level that maybe you have an eye on that might be a barrier or challenge as we are trying to expand our rural health care, trying to transform our rural health.
Yes, I would have to look into that a little bit further. I know that there were some loan restrictions. This funding is not, there are federal programs for loan repayment, and so this funding can't be used for that. But as far as what would hinder further health professions, I would need to look into that and get back to you.
Okay, appreciate it. Thank you.
Thank you. I just got a couple follow-ups off of Representative Granville's questions. One, from my work with the LEO budget, I know that we've got about $1.5 billion being invested in rural broadband through the My High. There's a lot of them out there, so that is ongoing of the investment in rural broadband. But you also asked about some of the workforce components of this, and I appreciate you giving a little bit more clarity on the indirect cost that seems to be absorbed by the subrecipients, that is for their admin costs that they're allowed to charge. And you said that you'll have some auditing in place there to make sure that that is used appropriately. We received the governor's exec rec about 3 weeks ago. And a significant portion of the increase of FTEs was related to DHHS. And through the presentation with House Fiscal, sound like a lot of those are going to be community health workers or some type of jobs like that. How many of those FTEs are going to be related to the rural health transformation, or will there be some kind of crossover with what you're trying to do with rural health into that community health worker side?
I'm not certain on the reference to the budget. I can tell you this funding pays for 2 FTEs from MDHHS, so I don't think there's any crossover, if that is your question. Sorry.
So there's just 2 that are related to the rural health?
Yes.
Okay, because I guess a bigger part of that is that a lot of them, from what I understand, that the FTEs are going to be caseworkers as well as maybe some community health workers, or is it not related to community health workers?
I'm not certain on the reference. I
Okay.
apologize.
I guess one of the concerns being that this proposal, and I think this is a question also about the sustainability of the proposal. This proposal seems very similar to the SIM, the state innovation model, and the blueprint that was put out back in 2014. And a lot of focus there was related to community health workers, the shires, which I certainly worked on at the time. And looking at that and kind of seeing what this is, it seems very kind of similar concept. And I guess having gone through that and the state spending $70 million, $73 million over that time, I don't know if we see much from that. I guess I have a concern after or when year 6 hits, what are we going to see after that? Where there'll be sustainability with this model? Will things continue to move forward?
That's a great question, thank you, and certainly part of our concern as well with the sustainability for these grants. It's something that we have at the top of our mind. Some of these activities, won't need to be sustained in that way, like providing technology funding and things like that. But certainly for some of the larger programs that would involve increased services, there will need to be the ability to prove that they're successful in order for additional funding to continue. So it's something we have an eye on, and we're hoping that evaluation will help prove some of the success of those programs.
Representative Robinson.
Thank you, Chair. I know we're getting caught up in some of the specifics, but I want to go back. I know for myself, when we heard that we're going to get less money than we thought we should because of our rural area, everybody got caught up on the rural health part of that fund. The transformation fund, is there anything in our proposal that maybe we could have been hit on that wasn't transformational enough? And I'm not so much worried about chewing on yesterday's breakfast. I'm just worried about moving forward. How can we, is it the transformational part of that fund that maybe we're not pulling our way? Is there any transformational projects in the proposal? And if so, what core areas do they hit? If you could talk to that.
Yes. So our proposal, in order for it to have been funded and approved by CMS, they deemed it to meet the mark of the application and the criteria that they set out. And so our proposal, there's an element of transformation within every single activity that we plan to roll out with this funding. We haven't received any feedback from CMS that there's any problem with the activities that we propose, that they're not being transformational enough or anything to that nature.
What do you think is the most transformational thing in the proposal that we sent?
Well, that's a great question. I think that the technology portion has the ability to impact the most as far as delivery of care. Because some of those tools have really changed the coordination of care, the ability for providers to do their own administrative tasks without that being a burden so they can see additional patients. So I do think that implementing some of those technologies and being used effectively is a big part of the issue as well, that will be a huge transformation.
Representative Kuhn.
Thank you, Chair. Question that has come up is on the technology, that some of the technology cost is massive, and the grants will not in any way be sufficient for smaller and independent hospitals to actually utilize it. How do you address that issue?
That's a great question, and certainly a couple of things I want to share. First of all, the technology fund was limited by CMS to be 15% maximum of our awarded grant. So we do have that same concern that there are huge costs that probably will not be able to be fully addressed by 1 year of this funding. However, it is over 5 years, and so we do think with the additional 5 years, we should be able to accomplish quite a bit.
Representative Roth.
Thank you, Mr. Chair. Thank you again. I would suggest the budgeting part of it, getting the money out by October 1st makes a lot of sense since that's our fiscal year, for gosh sakes. Has there been more conversations of how we determine partially rural and rural?
So the partially rural or fully rural determination is set by the Federal Office of Rural Health Policy. It is completely their data set. Michigan and at least 23 other states used that same data set to determine the fully or partially rural counties in their states.
I thought there was an option for us to use other information. No?
Yes, and so we set a prioritization on top of that. I think it's a slide. It's slide 14 in your deck. So on top of the partially and fully rural, we also plan to look at several different factors that point us to the highest need. And we think that these factors do showcase the highest need areas in Michigan.
Yeah, that's obviously, I will continue to bring up Leelanau County, even though it's not even my district, but it is partially rural. It's 22,000 people. In Northport's 45 minutes from Traverse City downtown.
Yeah.
How that can be still classified as partially rural, I don't get. That one's going to continue to bug me. I think we need to look at other options, how close you are to healthcare facilities. It needs to be a real big part of it. I would appreciate if the department takes a close look at that and takes another look.
Okay, thank you.
Thank you, Mr. Roth. Specific, again, to the proposal, your submission talks about how regional collaboratives will generate savings to be reinvested. This goes kind of to the sustainability, what happens after the funds run out. But I was curious if you could explain maybe some examples of how a regional collaborative would get savings and that money would be available then moving forward.
Yeah, I think there are a couple of examples, but I'm not sure what specific you're referencing in our proposal. I would have to.
I think it was just in general that some of these projects, it was under the sustainability section that by having some regional collaboration, this is going to generate some savings that will then be reinvested.
Yeah, so one example might be the advanced discharge planning from hospitals for older adults. I think that could, is anticipated to really have some savings to make sure that upon discharge, everything they have is needed to reduce readmission or reduce additional care. So that is one of the regional collaboratives with the area agencies on aging with the hospitals as well. So that's one example.
Yeah, as everyone here on the committee has met with healthcare professionals talking about how savings are generated if we spend money this way. I guess I'm curious about how more dollars or revenues would come in with regional collaboratives.
Oh, generating revenue
Right.
with, yeah, I'm not sure. It was meant to be a cost savings.
Okay. Obviously, a major component of this is the workforce development and the talent side. I've certainly, with my committee work, have done a lot with workforce development and trying to generate talent. It's been a long time coming here in the state of Michigan. This committee is familiar with the MyDocs program that is a part of this budget. Do you see best practices out there? Do you see programs that is truly going to generate? I know that there's been efforts along the way. Many millions of dollars have been spent in the state trying to recruit talent and retain and build skills. What proven model out there have you guys looked at that is going to generate the needs that is needed in our rural communities?
Yeah, that's a great question. And for workforce, two things, despite continued study, constant study, continue to be true. And that is where the provider is from, where they grew up, highly dictates where they'll practice. And then where they trained will also dictate where they practice. And so keeping those two things in mind, the most successful models that have been proven sort of repeatedly are able to find students or older adults who want a second career, or whoever it may be, from rural communities to work in rural communities. That's a successful model. The second model is taking a provider who may be trained in a rural community. The chances of them going to a rural community or staying in that community are very high. So any programs that incentivize one of those two things, or maybe even both of those things, has proven to be successful.
Thank you. And I think this is kind of a follow-up to Representative Ross' original question. So other states are supporting rural hospitals directly. I believe the proposal allows up to 15% of the funds to go directly to rural hospitals. Why did you choose not to include this as part of the proposal?
Thank you for that question. I appreciate the opportunity to clarify. CMS told us that, and published in their FAQ, that 15% note in their notice of funding opportunity has to correspond with the initiatives that we proposed. And so it can't be a standalone initiative of 15% of the award going to rural hospitals to maintain their current status. It has to be 15% can go towards a provider's salary or a provider's payment if it's not duplicated in any other way, and it is falls within one of our initiatives. And so the idea that we could write in, just 15% of our award checks to hospitals would have been rejected by CMS.
So is that part included, though?
Absolutely.
That the salary component and programming part?
Yes.
That is included in the application?
Yes, that is part of the indirect, because any personnel costs or fringe or travel are part of the administration. And so that has to be below the 10% threshold that we are tracking separately.
Okay. Yeah. Representative Kuhn?
Thank you, Chair. Just to follow up on that, did you have any initiatives that would allow you to do the 15%?
Yes, particularly in the care close to home activities. The hub and spoke model is specifically for that, to expand services into rural areas. And so that is meant to provide for those services. That funding is meant to provide for those services in those areas. The same as the advancing rural health, some of the models we want to put in place will provide or will require payments to providers.
Okay, but you didn't put in the 15%, right? I mean, I don't understand. You said you have to have an initiative, and you say you had initiatives, so why didn't we get the 15%?
We did.
Okay. There is going to be 15% given to each of these providers. Is that what you're saying?
No, that is not what I'm saying. I apologize. What I'm saying is that the 15% could go to payments to providers if it wasn't duplicated already and it corresponds to one of our activities. And so if one of the activities requires a payment to a provider, that will be in the cost of this grant. And we have to monitor that to make sure it doesn't go above 15% of the total award. We also have to balance that with a 10% cap on administration costs as well. There's several different factors that CMS has us juggling.
Thank you. So with the 15% had to be kind of correspondent with a proposal that was put in. I guess this goes to some earlier questions on the stakeholder input. We have certainly seen some of the stakeholders and what they were seeking to be a part of this plan. Some had very specific proposals that they wanted to see as part of this plan that were not included. So I guess the question is why when meeting with those stakeholders and they having those specific proposals that probably would have qualified for that 15% were not included in the administration's proposal?
Yeah, thanks for that question. We wrote this proposal to walk a very fine line, to be high level enough to include all of the great ideas that were brought to us in the, I think it was 51 days that we had to submit this proposal, but also broad enough to recognize that in the 51 days that we had to do the proposal, we couldn't have heard all of the great ideas. And so many of them aren't listed specifically, but are described as a potential outcome in the proposal. And that's the purpose of our proposal-based grants, is to be able for a local hospital or a local clinic to say, this is exactly what we need, and then for us to be able to provide that funding. So we did not in our proposal list, every idea that came to us on purpose, so that because we knew that we would need to be much more broad to allow for all kinds of activities and all kinds of ideas that either hadn't been brought to us or that will evolve in the next 5 years.
Representative Roth?
Just to follow up with that, keep going all day today. Are there things that you are proposing to change for next year's plan that you can share with us right now?
The answer to that question is probably yes, but we don't know what they are yet. We're so early into the implementation. I'm certain that there will be changes that will need to be made, and that is one of the main goals of the advisory board, is to be able to help advise us on some of those changes that need to be included going forward.
The only worry I have is that if we don't get this going quickly, obviously the plan's going to take place here shortly.
I
So,
share that worry.
yeah.
Thank you.
In your slide, well, you had just talked about the grant-funded opportunities as well as the proposal-based grants and the directed grants. Is there a ratio here that you're looking for of how much is going to be kind of the RFP process and how much is going to be the direct?
That's a good question, and I think I could come up with that, but I couldn't on the spot. I could follow up on that.
Okay. You mentioned kind of as you put the proposal together and the time frame you had in there, we've talked about specifics and other things. You said kind of the high level. I think it goes into some questioning by Representative Kuhn and Representative Robinson of there's a concern here that, the technology won't be enough, of the cost that is related to technology. Are you really putting a dent into that area and the need that's there? And you look at this and already how many, you got the 4 broad categoricals that you're trying to achieve, and yet within them probably 12 subcategoricals in there that you're trying to achieve. I think there's a concern that this is just going to be spread thin. And then to Representative Robinson's, what's the big goal here? What's the big idea? What's going to be the actual transformation? And I think when you're looking at other states' proposals, they kind of had a piece in there that they were going after something very, very specific. I guess, what's kind of your thoughts on that as you going through this process of what is it that we're really trying to get here and achieve, and are we spreading ourselves too thin, trying to maybe appease everyone?
Thank you for that question. My immediate reaction is that, it is funding over 5 years. And so while we have, these 4 categories, I think that CMS has allowed us the flexibility perhaps in the future to say, maybe we don't need all of this. Maybe we need to consolidate. I think that is a possibility. I think at this time, though, when I look at all 4 of our activities and all 4 of those components, I think they're all really important, and they all cross over. They all have a lot of coordination amongst them. So at this point, I would say I think it hits a good mark of being able to see what we can do and see what can be successful, with the idea of refining that over the 5 years and perhaps focusing more on those things that are successful.
Representative Kuhn?
Yeah, sorry, Chair, but thank you very much. you know, I'm from Oakland County, and I know apparently we're partially rural. And you compare the health centers that are available in Wayne and Oakland County and their ability to actually fund things that are massive costs compared to smaller hospitals. I'm a little concerned that instead of getting to the real needy hospitals, that the people who are able to actually apply for some of these grants are going to be very, very big hospitals in so-called partially rural areas.
I'm sorry, what was your question?
Well, how do you address that kind of a problem? I mean, to me, that's a problem. I mean, sure, you have the funds, and you give a grant, say 200,000 for something, and the cost is 20 trillion, and the only people who can afford it are the Corwells or the Henry Ford Healths, and they make the application because they are in Western Wayne or they are in Oakland County.
Okay, so, I think that, that we share that exact concern and proposed this prioritization framework to help address that. So for the partially rural counties, we're going to first look at how many people are living in those rural areas within that partially rural county. And so I would hope that that would address some of your concern. And then additionally to that, we're looking at the chronic disease burden in those areas, and then the access to hospitals, primary care, maternal health services, and mental health services as well. Additionally, socioeconomic factors like Medicaid usage, child poverty rates, and the percentage of aging population to help adjust for those issues. So that the proposals are not just based on, how well done the proposal is, but these other factors as well.
Representative Rogers.
Thanks. Just going down on this road, though, I do agree with my colleagues, and I think there needs to be some consideration. I think the point that we're trying to make that we would like to see is that that there is some kind of prioritization for the geographical, truly rural, because they don't have the access. So I'm not trying to pick on Wayne County, but again, in parts of rural Wayne County, when you do the drive to the nearest hospital or FQHC kind of facility, it's probably going to be a lot shorter than, say, our friends in the UP, where it may be a 2-hour drive. And so as you're trying to decipher in all these buckets of how, I think there's a lot of sentiment on this committee that we would like to see prioritization to some of those geographically less dense communities where there's fewer facilities for them. Thank you.
Thank you. Just, I guess, doing a cursory look at the first tranche here of the money going out. I guess it's a question of how you guys are tracking the dollars. First blush, it looks like a lot of associations that are based here in Lansing. Are you guys keeping track of how much of those dollars are actually going into rural communities rather than, you mentioned the indirect cost and the administration and that kind of stuff like that, but there's a lot like studying and consulting and things like that money is going to. Is the department planning on tracking how much dollars are actually going into communities rather than some of this consultation and Lansing associations?
The answer is yes, we are certainly tracking that. However, I'm not sure what you're referencing with consulting. I don't believe that we have any consulting other than the
First one off the
evaluation.
bat is the 2.5 for MPHI as consulting, but I see there was Health Care Workers Association that's getting money. And I get that money goes into eventually into the programming. So I guess it's partially an auditing question, how we know that the money is being actually going into the field rather than the studies and the reports and things like that.
Yes, so the funding has to go into the field. It cannot be used for anything for CMS that isn't part of the transformational work. And so if you're asking if we'll do recipient and subrecipient monitoring, the answer is yes.
Yeah, there's money that goes to, you know, the association to coordinate and things like that. And then there's actual dollars that go into the field and are improving. You know, it's kind of the discussion of rural hospitals. Are they actually getting the money going in, or is the association doing the study and holding funds?
So where we have contracted or proposed to contract with associations, it's on behalf of their members to alleviate the fiduciary burden of the grants. There isn't anything associated with consulting or writing a report that I'm aware of.
Okay, thank you. All right. Seeing no further questions, thank you very much for being here and answering all our questions. Very much appreciated. I know we'll continue to be looking at this issue as we're moving forward. We know you guys got a lot of work, and this is obviously a very important issue for the committee and for many legislators. So we look forward to having that dialogue.
Great, thank you.
Seeing no reason to excuse members, thank you all members for being here. The committee is adjourned.
Thank you.